Right now, millions of adults over 65 are taking blood pressure medications every single morning, trusting that those pills are protecting them. And most of the time, they are. But there are specific blood pressure medications prescribed millions of times every year that have a hidden problem your doctor probably has not discussed with you. When taken in certain combinations or when combined with a common pain reliever, they are quietly damaging your kidneys. And what makes this so dangerous is that you feel absolutely nothing until it is serious. Kidney damage from medication does not hurt. There is no burning, no aching, no warning signal your body sends you. By the time most people find out there is a problem, they have already lost a significant portion of their kidney function permanently. And once kidney function is gone, it does not come back. This channel is dedicated to bringing you the latest evidence based research on senior health in a way that is actually practical and easy to use. If you have not subscribed yet, I would encourage you to do that now so you never miss what we are covering. Today, I am going to name 4 specific medication categories, explain exactly how each one affects your kidneys, identify the dangerous combinations, and give you the precise questions to take to your next appointment. Stay with me until the end because the 4th item is not a single medication. It is the combination that a 2025 nationwide cohort study identified as one of the most dangerous drug interactions in elderly hypertension management. And it is one that millions of seniors are currently living with unknowingly. Before I name the 4, you need to understand what makes the kidneys so vulnerable to medication damage after 65. Your kidneys filter your entire blood volume approximately 40 times every day. To do this, they rely on a precise and constant blood pressure inside the tiny filtering units called glomeruli. If the pressure drops too low, the kidneys cannot filter. If the pressure is disrupted by a medication that interferes with the hormonal system controlling it, the filtering units are damaged. After 65, the kidneys have already lost a meaningful portion of their reserve capacity through the normal aging process. Adults can lose up to 50% of kidney function before any blood test shows abnormal results. This means the kidneys of a 68-year-old are working closer to their limit than the kidneys of a 40-year-old, even when every test comes back normal. Any medication that interferes with kidney blood flow or disrupts the pressure balance inside the glomeruli is hitting a system with far less margin to absorb that interference than it had 20 years ago. Medication category 1, diuretics at high doses. Diuretics, commonly called water pills, are among the most prescribed medications for high blood pressure in adults over 65. They reduce blood pressure by causing the kidneys to excrete more sodium and water, reducing blood volume. The most common examples are furosemide, hydrochlorothiazide, and chlorothalidone. The kidney damage mechanism from diuretics is volume depletion. When diuretics cause the body to excrete too much fluid, blood volume drops. Reduced blood volume means reduced blood flow to the kidneys. When the kidneys receive less blood, filtration slows, waste products accumulate, and in acute situations, the filtering cells themselves can be damaged. This is called pre-renal acute kidney injury, and it is particularly dangerous in older adults because the aging kidney has less capacity to compensate for sudden drops in perfusion. Kidney damage is more likely with higher doses of diuretics. Dehydration, hot weather, illness involving vomiting or diarrhea, and reduced fluid intake all amplify the risk dramatically. A senior on a high-dose diuretic who has a stomach illness for 2 days without adequate fluid intake is at genuinely serious risk of acute kidney injury. The kidneys are receiving inadequate blood flow at precisely the moment their filtering cells are already under stress. The practical instruction: if you take a diuretic and experience vomiting, diarrhea, or any illness that reduces your ability to drink fluids, contact your doctor the same day about whether to hold the diuretic temporarily. Do not make this decision yourself, but do not wait until the illness has passed either. Medication category 2, ACE inhibitors. ACE inhibitors are prescribed for high blood pressure and for heart and kidney protection. You recognize them by names ending in pril, lisinopril, ramipril, enalapril, perindopril. They work by blocking a hormone system called the renin-angiotensin system, which relaxes blood vessels and reduces blood pressure. Here's the specific kidney mechanism that most patients never hear explained. The kidneys use the same renin-angiotensin system to maintain the internal pressure inside each glomerulus. When blood flow to the kidney drops, even slightly, the kidney uses angiotensin to constrict the small vessel at the outflow of each glomerulus, maintaining internal filtration pressure despite reduced incoming flow. ACE inhibitors block this compensatory mechanism. In patients with normal kidney blood supply, this is well tolerated. But in patients with narrowing of the arteries supplying the kidneys, a condition called renal artery stenosis that is more common after 65 and often completely undiagnosed, ACE inhibitors can cause the internal kidney pressure to collapse, producing acute kidney failure. ACE inhibitors can cause kidney failure in patients with kidney artery narrowing because these drugs work by reducing the kidney's ability to maintain blood pressure during times of reduced flow. This is not a reason to stop an ACE inhibitor without medical guidance. For most patients, ACE inhibitors are genuinely kidney protective. The important action is ensuring that kidney function, specifically serum creatinine and eGFR, is tested within 2 to 4 weeks of starting or increasing the dose, and that the doctor is aware of any existing kidney disease. Medication category 3, ARBs. ARBs, or angiotensin receptor blockers, work through the same renin-angiotensin system as ACE inhibitors, but at a different point in the pathway. Names you may recognize include losartan, valsartan, irbesartan, and candesartan. They carry essentially the same kidney risk profile as ACE inhibitors in patients with renal artery stenosis or significant existing kidney disease. The important distinction between ACE inhibitors and ARBs for kidney safety is that combining them together, called dual blockade, increases the risk of acute kidney injury significantly compared to either drug alone without providing additional blood pressure benefit in most patients. Major clinical guidelines now recommend against combining an ACE inhibitor and an ARB due to this increased kidney risk. If you are taking both, this is one of the most important medication review questions to raise with your doctor. If you have made it this far, you are clearly invested. You want to see what happens next, but most viewers enjoy the content and scroll away without subscribing. If this one really means something to you, tap subscribe. It takes a second. If not, you will probably forget this channel exists and miss a lot of great educational content ahead. Over the years in my clinic, I have seen one simple truth. Real progress does not come from doing anything extreme. It comes from doing the right small things consistently every single day. That is exactly why I created the 30-day blood pressure reset for seniors. It is a simple step-by-step plan designed to help support healthy blood pressure through gentle daily routines, light exercises, and clear guidance you can easily follow at home. The connection to kidney health is direct. Consistently controlled blood pressure is the most important thing you can do to slow kidney decline. Blood pressure spikes are one of the primary drivers of glomerular damage. The daily habits in this guide work precisely to reduce those spikes. Some of my patients and people who have already gotten the guide have shared that they feel more in control of their daily habits, more confident about their readings, and more at peace knowing they are finally doing the right things. For many of them, it was not about drastic changes. It was about having a clear, simple plan they could actually stick to. I am only allowing 30 people through it right now because I want to follow up closely. Click the link in the description or scan the QR code before the spots are filled. And because you are part of this community, I have made it easier with a 70% discount. After you get your copy, drop your email, and I will personally follow up with you. Now let us cover the most important category on this list, Medication category 4, the triple whammy combination. This is not a single medication. It is the combination that represents the highest kidney risk of any scenario I have described today. And it is one that an alarming number of older adults are currently living in without knowing it. The triple whammy is the combination of three drug types taken together: a renin-angiotensin system inhibitor, which is either an ACE inhibitor or an ARB, plus a diuretic, plus a nonsteroidal anti-inflammatory drug, which is an NSAID, like ibuprofen or naproxen. Here is why this combination is so dangerous to the kidneys specifically. The diuretic reduces blood volume, lowering blood flow to the kidneys. The ACE inhibitor, or ARB, removes the compensatory mechanism the kidneys use to maintain internal filtration pressure when blood flow drops. And the NSAID, by suppressing the prostaglandins that dilate the incoming kidney blood vessels, further reduces blood delivery to the already stressed glomeruli. All three mechanisms act simultaneously on the same filtration system. Patients receiving NSAIDs chronically, in combination with diuretics and ACE inhibitors or ARBs, are at risk for elevated serum creatinine and acute kidney injury. A nationwide cohort study published in August 2025 examined 41,904 patients on this triple combination and confirmed that the risk of acute kidney injury was significantly elevated, with the risk particularly concentrated in the first 30 days after adding an NSAID to the existing combination. The median time to kidney injury onset in triple whammy cases was just 6.5 days. The NSAID is almost always the drug added last. A person already on an ACE inhibitor and a diuretic for blood pressure takes ibuprofen for a few days because of knee pain or a headache. That seemingly minor addition, repeated over days or weeks, is what tips the kidney system into crisis. If you take an ACE, inhibitor, or ARB for blood pressure, and you also take a diuretic, you must avoid NSAIDs, including ibuprofen and naproxen, entirely, or use them only under direct medical supervision with kidney monitoring. Paracetamol, also known as acetaminophen, does not carry the same kidney risk and is the appropriate alternative pain reliever in this situation. Let me bring this together clearly with the 4 questions to take to your next appointment. First, what is my current eGFR and has it been tested in the last 6 months? The eGFR is the blood test that estimates kidney filtration capacity. Every person over 65 on blood pressure medication should have this tested at least annually. Second, am I on both an ACE inhibitor and an ARB? If yes, this dual blockage should be reviewed given current guidelines discouraging the combination. Third, am I on a diuretic combined with an ACE inhibitor or ARB? If yes, am I aware that I must avoid NSAIDs, including ibuprofen and naproxen, and that I should contact my doctor during any illness involving vomiting or reduced fluid intake? Fourth, what is the safe pain reliever for me given my current blood pressure medications? These 4 questions asked at your next appointment are the practical outcome of this video. Before you go, think about this for a moment. Most people keep waiting for the perfect time to take their health seriously, but that moment usually never comes. That is exactly why I put together the 30-day blood pressure reset for seniors. It is designed to help you follow a simple, structured daily routine that supports healthy blood pressure without confusion or stress. Inside, you will find gentle exercises, practical daily habits, and a clear step-by-step plan you can actually stick to. Some of my patients and people who have already gotten the guide have followed this exact structure and started seeing real, noticeable improvements. Many have shared that they feel more in control of their habits, more confident about their readings, and more at peace knowing they are finally doing the right things. For many of them, it was not about drastic changes. It was about having a clear and simple plan they could follow consistently. And that is what made the difference. I am keeping this very limited. Only 30 spots are available and 15 are already gone, which means just 15 spots are left. Once those spots are filled, I will close it. Click the link in the description or scan the QR code to secure your spot now. And because you are part of this community, I have made it easier with a 70% discount. After you get your copy, drop your email, and I will personally follow up with you, checking in and helping you stay consistent with the plan. Tell me in the comments, are you currently taking any of the combinations I described today? And has your doctor ever tested your EGFR alongside your blood pressure review? I read every comment. Share this with someone over 65 who manages blood pressure and takes ibuprofen for pain without knowing the risk. That information could protect their kidneys before permanent damage occurs. Your kidneys are working silently for you every single day. Give them the protection they deserve. I will see you in the next one. Disclaimer: everything shared in this video is general educational information based on published peer-reviewed research, including a 2025 nationwide cohort study on triple whammy acute kidney injury, Pharmacy Times clinical review, Good RX medical reference updated February 2026, and current KDIGO clinical practice guidelines. It is not personal medical advice. Do not stop or change any medication without consulting your doctor. If you experience sudden reduction in urine output, swelling, or unusual fatigue while on blood pressure medications, seek medical evaluation promptly. This information is a starting point for your medical conversations, not a replacement for them.